And also I'm not going to cover the lecture topics we were already doing. Okay, and so I would try to cover rest of the topics. You just had like a nutrition lecture. We would try to leave those, but we would try to cover most of the general GA stuff. So it's not, the cursor is not moving. Need to use. Yeah. So what we would try to do is we would put some questions on. We will do that question, and we are going to discuss a little bit about that specific topic. Okay. So any one of you wants to read the question?
Read it?
Yeah.
Oh, I can read it.
Mm-hmm.
Like out loud. 7-month-old infant is admitted to the hospital with edema, hypertension, anemia, and hypertension. They've been gaining weight well and is an excellent health while exclusively breastfed. 5 months of age, oatmeal and wheat cereals were introduced into his diet. 1 month ago, he developed watery diarrhea, appeared to have abdominal distension, and became weak. He also stopped gaining weight. Of the following, the most likely cause of this infant's symptoms is.
Okay, so what do you think? Okay, C. Okay, so where do you think the answer is C? Yes, that's right. Mm-hmm. And he has failure to thrive, right? And in addition, the most important thing here is iron deficiency anemia. So whenever you see a word iron deficiency anemia, in addition to vitamin D deficiency, and especially this iron deficiency anemia is resistant to oral iron treatment. If you see that, then most likely it's going to be celiac disease on your exam. Okay. So we are going to go over a little bit of a little bit about celiac disease. We all know it's an autoimmune condition, but it's a peculiar autoimmune condition because how many autoimmune conditions you can see which can be treated without using steroids or immunosuppressive medications. But this is one condition where you can just put them on gluten-free diet and they would be able to do well lifelong. So it's an autoimmune condition which can happen in genetically predisposed individuals. And most of the common HLA types you would see is DQ2 and DQ8. Okay. So and also here the issue is the gluten. Gluten is a group of proteins. Like gliadin is one of them. Almost like 50% of gluten proteins in wheat is gliadin. And your body produces this anti-gliadin antibodies and anti-tissue transglutaminase antibodies, which would damage your small bowel villi and small bowel enterocytes. So this is a typical growth chart for celiac disease. And most of these kids would be diagnosed around 9 to 15 months of life. But like celiac has a big broad spectrum where you can have a silent disease without having any symptoms or major manifestations. In those cases, diagnosis might be late, or sometimes you were never diagnosed. So, but in classic celiac disease, typically you would see that weight drop in percentiles after you introduce gluten in their diet, and you could see even the height kind of like going down there. So in a classic, again, you can have intestinal manifestations or extra-intestinal manifestations of celiac disease. So the word classic is being used because it's presenting with classic GA symptoms. So you can have typically abdominal pain, abdominal distension, and also either diarrhea or constipation can be the major manifestations in addition to failure to thrive. And coming to extra-intestinal manifestations, like many of these manifestations, they might not be associated with GA symptoms. So if you see these specific findings on exam, you might need to consider celiac disease in the diagnosis. So suppose if you take dermatitis herpetiformis, it's not very common in younger kids, but it can happen in older kids as well as adults. So we are going to look at a picture of dermatitis herpetiformis anyway. So these kids can also have dental enamel hypoplasia, and also you would see osteopenia and osteoporosis related to vitamin D deficiency. And you would see, especially in older kids, you would see delayed puberty sometimes with celiac disease. And more older people, you can also see infertility. And recent studies has also shown that celiac patients can present only with neurologic symptoms. Sometimes your symptoms can be headaches, ADHD type of symptoms with anxiety, and you can have declined school performance or neurocognitive decline. And there are cases which reported dementia, ataxia, neuropathy cases with celiac disease without having GI manifestations. And again, we talked about iron deficiency anemia, and you can also have arthritis associated with celiac disease. Again, now there is like lots of screening for celiac, right? So any kid we see diarrhea, we would like screen them for celiac. So with that, we are kind of like picking them up very early. But in the old days, you know, like you were seeing actual classic manifestations of celiac disease. So the kid on the right side, you would be able to see that significant abdominal distension. And that was one of the classic manifestations of celiac disease. Picture on the left, you could see that, muscle emaciation, as well as if you look at the knee area, you would see that widened metaphysis, right? Which can be associated with rickets. So if you see that again, that's celiac disease. Again, here, lab findings, as we discussed before, anemia in this case is mostly iron deficiency, but sometimes you can have folate or vitamin B12 deficiencies. You can have transaminitis. Again, the transaminitis here is called celiac hepatitis. So again, it's considered as an autoimmune process where the findings are very mild. You would see very mild AST, ALT elevation without having any major liver dysfunction. And decreased albumin level is more related to malnutrition and protein malabsorption. So here you can see dermatitis herpetiformis. So it's a papular vesicular rash, which is distributed on the extensor aspects, right? So you could see it on the elbows there and on the knees, and you would be able to see it on the buttocks as well. And it's associated with severe pruritus. And almost like 90% of these patients, they would not have any GI complaints. But if you do an endoscopy, you would be able to demonstrate villus atrophy. Again, these are the endoscopy findings. On the extreme left, you can see normal appearing mucosa. You could see those multiple folds over there, right? You could see those multiple folds. So that's how a normal duodenum should appear. And although it's not a closer look, you could see the villi are robust and more like those are the finger-like projections. On the extreme right, you could see the same small bowel. You could see it's nodular. It's more because of lymphoid hypertrophy, which can be a finding in celiac, and also decreased folds. You can see the number of folds has gone down. And in the middle, you could see on one fold, you could see those divots. That's called scalloping, which can be a manifestation of celiac disease. Those are the gross endoscopy findings. And histology on the left side, you could see nice long villi. So how they are helpful, see how much surface area they have because of these like villi. But on the right side, you see all those are like completely blended. Now you have a flat surface. And you could see how much compromise in that absorptive surface area. Because of that, you develop all these findings we just discussed before. You would be able to see elevated intraepithelial lymphocytes, which is the other finding in celiac disease, in addition to villus atrophy. So then again, treatment, you all know, we need to avoid gluten for lifelong. So you need to avoid wheat, rye, barley, and oats. It's kind of questionable because it has certain types of gluten proteins, but research has showed that celiac patients were able to tolerate it much better when compared to the remaining cereals. So with that, wheat is kind of questionable, but major things you need to remember: wheat, rye, barley, completely restrict. Okay, so next one is, again, it's a high yield topic, Hirschsprung disease. So Hirschsprung disease, so typically happens in a full term and appropriate for gestational age impact. The most important thing you would be looking at the birth history is if they passed their meconium within the first 48 hours. But unfortunately, this finding is not specific, not sensitive for your Hirschsprung disease. And almost 50% of Hirschsprung disease patients, they pass this test, they pass the meconium within the first 48 hours. But if you see any baby, if they say no meconium in first 48 hours, you need to definitely rule out Hirschsprung disease. So they need to have the testing for Hirschsprung disease. So again, so what is the problem in Hirschsprung disease? You have problem with neural crest cell migration. So in the embryonic period, around like 7 to 8 weeks of life, you have your foregut And on top of it, you have like a vagal crest where your neural crest cells are situated. Once your foregut is formed, these neural crest cells are going to enter into the esophagus. Then they go down in a craniocaudal fashion. That means typically the proximal gut is innervated first, followed by the distal gut. So that's the reason why you always see Hirschsprung involvement in the most distal areas, right? Rectum and sigmoid. So almost 80% of cases are rectosigmoid involvement. What does it mean? That means your neural crest cells were able to progress until your sigmoid colon, and that's where they got arrested. So your rest of that distal colon, your rectum and sigmoid area did not have the ganglion cells. And what does ganglion cells do? So they would not contract your bowel. They help in relaxing your bowel, right? So when you have no neural crest cells, your bowel, where your neural crests are missing, it's going to be contracted and it's going to be narrow. So that's the reason why when you are looking for a transition zone, although we always feel the dilated zone is the abnormal zone, that's not the abnormal zone. It's the narrowed portion is the one which got affected, and the top portion is trying to take that fecal burden and the extra gas, and it gets dilated. So I think we can, and again, in terms of association, Hirschsprung disease can be significantly associated with your Down syndrome. So if you were given a Down syndrome baby, if they mention about bilious emesis or abdominal distension with constipation issues, you need to rule out Hirschsprung disease. And also the RET gene is like one other gene they would typically ask you, because it has that's one of the causative factors. There are almost 100 genes, RET, R-E-T, RET gene, okay? And again, a classic description of a Hirschsprung disease baby. Again, most of these babies were diagnosed pretty young, but it typically depends upon how long segment of colon is involved. As we mentioned, 80% of cases are rectosigmoid involvement, but you can also have total colonic Hirschsprung. That means your neural crest cells got arrested at the IC valve. So you don't have any neural crest cells in colon. So now your colon is going to appear small and narrowed, right? So it appears like a microcolon. So in those cases, you are not able to see a transition zone. So the other thing, other important thing in clinical practice is you are going to see small caliber, narrow stools with Hirschsprung disease. In contrast to functional constipation, where you hear from parents, they can have very large, bulky, big bowel movements. So the fact that you have a very narrow rectum, when the stool passing through that narrow rectum, it's going to become ribbon-like or narrow. And in addition, when you are doing a rectal exam, the same thing, right? You feel like your opening is kind of snug around your finger, and you feel like you're passing your finger through a glove, right? Because so when you're putting the glove, it's kind of approximates to your finger. You feel the same thing because you're passing your finger through a narrowed canal. And at the same time, there is no stool there because it's kind of obstructed. And once you are able to enter into that capacious dilated segment, you would be able to feel the stool there. But a good long distance, you won't feel the stool. And when you remove it, you are kind of partially relieving the obstruction. So you would be able to see something called squirt sign. So where explosive diarrhea or explosive expulsion of contents would happen. So that's again a sign for Hirschsprung disease. Again, it's not sensitive or specific, but that if you see that, then you need to rule out Hirschsprung disease. Whereas in your functional constipation, your rectal exam, you have loose external sphincter. It would not be fitting nicely around your finger. And immediately you would be able to enter this capacious big rectum or mega rectum, right? But the functional constipation, what's happening there? You are holding stool for a long time. Where are you holding the stool? In your rectum, right? So rectum can get distended and becomes a big voluminous chamber. So you could see this difference in the clinical exam. So especially if you have a baby of 3-month-old, 6-month-old, when you are doing a rectal exam, these are the things you need to keep in mind. So we discussed almost 80% cases, they involve rectum and sigmoid. And the genetic testing is not really indicated because there is a low penetrance. It does mean, even if you have those chromosomes, it does not mean you are going to have Hirschsprung disease. And diagnostic findings, So if you do an abdominal X-ray in these patients, one thing you would find is they would have dilated bowel loops with paucity of gas in the rectum for the same reason we discussed before. So, and typically prone position is indicated because when you are in the prone position, typically in a normal kid, the air moves into your rectum. But here you have obstruction. So even if you put them into a prone position, you would not see air in the rectum. And you also need to do unprepped contrast enema because you need to see the transition zone, right? If you are doing this test in a 2-week-old or 10-day-old, you did not allow enough time for this proximal colon to get dilated. In those cases, if you do the test on a fully cleaned out colon, you're not going to see the transition zone because that bulges from the stool and from the contents. So you need to do it on a unprepped colon. And also, as we mentioned, if you have total colonic aganglionosis, there would be no difference there would be no transition zone actually. So this is a contrast enema showing transition zone. It's not very prominent, but you could see the sigmoid area. You could see it's kind of like dilated when compared to your distal portion, your rectum. So in a normal individual, when you get an X-ray or contrast enema, you are supposed to see a bigger rectum than sigmoid. But here it kind of reverses, right? So you have a narrowed rectum or small rectum, but sigmoid is kind of dilated. And again, again, if you have a positive transition zone on X-ray, it does not mean you are confirming Hirschsprung disease. It's more suggestive, right? Before subjecting them to invasive tests like suction biopsy or full thickness biopsy. So rectal biopsies are the gold standard for the diagnosis, right? And if you have a kid less than 6 months old, you would be able to do a suction biopsy because you need to get submucosa into the biopsies. That's where you are able to see the ganglion cells. So if you have a kid less than 6 months, do rectal suction biopsy. If you have a kid more than 6 months old, typically do a full thickness biopsy to visualize ganglion cells. And anorectal manometry, and again, it might be helpful, but again, not confirmatory. What you are looking for is something called recto-anal inhibitory reflux. So here, this is how a anorectal manometry cart would look like. And you could see the catheter with a balloon at the end of it. So that balloon, you would inflate it once you place it into their rectum, and it acts as a stool in the rectum. So in a normal individual, when you don't have stool in the rectum, your internal anal sphincter is closed. It's an involuntary reflex. Internal anal sphincter is involuntary sphincter, whereas external anal sphincter is voluntary. So if you don't have stool, it would be closed. But if you have stool, it stimulates the stretch receptors in rectum. So it automatically opens your internal anal sphincter. So whenever you are opening your internal anal sphincter, that means you are relaxing the sphincter. That means your pressure of the sphincter should drop. So on the top picture there, that's anorectal manometry from a functional constipation kid. So here you could see with rectal balloon, you put like 20 cc of air. Immediately after you put the air into the rectum, that acts like a stool and immediately drop the pressure in your internal anal sphincter. So that's the reflux you are looking for. In a Hirschsprung disease patient, see here, you put a rectal balloon and you put 40 ml of air, but you see an increase in the pressure of the internal anal sphincter instead of a drop. So that indicates the kid most likely have Hirschsprung disease, but again, still need suction biopsies to confirm. So suction biopsy, again, you are looking for ganglion cells. Absence of ganglion cells confirms Hirschsprung disease. And again, management might not be very important for you guys for the exam purposes, but what you are doing is you are cutting that portion where the ganglion cells are absent, but you are still preserving your internal anal sphincter and a portion of anus so that you won't develop incontinence afterwards, right? So you would pull this like the distal colon or ileum, and you would connect it to the distal stump. That's the surgery for Hirschsprung disease. Okay, so let's do this question. Who wants to read? Go ahead. Yeah.
If there's an obvious distress, other than mild tachycardia or vital signs are within normal limits. Your abdomen is diffusely tender without localization. Circulation reveals no tenderness or evidence of occult blood. Are the following most likely cause of the child acute abdominal pain?
Okay. What do you think, guys? E? Okay. What is the reason you chose it? Bilious vomiting. Okay. So small bowel obstruction, can it cause pain radiating to back? Right. So it's a tricky question. Yeah, definitely. But none of these other conditions should cause pain radiating to the back, because that indicates a retroperitoneal inflammation or irritation, right? That can only happen in pancreatitis. And although it's not typical of pancreatitis to cause bilious vomiting, you can have bilious emesis, right? So even like just take cyclic vomiting syndrome, right? You would be constantly vomiting. There is no obstruction, small bowel, but all your gastric contents are out. You might be able to bring these small bowel contents up. You would be able to have bilious vomiting. So again, most of the times you are supposed to see epigastric tenderness with pancreatitis, but sometimes, like if it is like severe necrotizing pancreatitis with third spacing and irritation of the peritoneum, you can have diffuse abdominal tenderness. So definitely most of us would go for small bowel obstruction if they didn't give you that, radiating back pain. Okay, so again, topic is pancreatitis. Again, as we know, most classic presentation is abdominal pain, nausea, vomiting. You can have like associated tachycardia, in some cases fever and hypertension. Again, as per current INSPIRE criteria, that's the criteria for acute pancreatitis, you need to have only two of these criteria, 2 of 3 criteria in order to diagnose acute pancreatitis. You need to have symptoms consistent with pancreatitis. It might be an epigastric abdominal pain with nausea and vomiting radiating to back, right? So that typically indicates pancreatic pain, right? Second thing is you need to have a 3-fold rise in lipase or amylase. If you have those 2 findings, like lipase elevation and symptoms consistent with pancreatitis, that would be enough to say kid has acute pancreatitis. You don't need any CT radiation or ultrasound, okay? Because we know this is a reversible process, right? Acute pancreatitis can be, in many cases, it can be idiopathic, and you might have recurrence in the future, but most cases, they might not have any recurrence. And most of the times, you might not see any structural changes. If you do imaging in these patients, you would be able to see pancreatic edema. Typically, that's one thing you will see. But in case, if you don't have, suppose the previous patient where we did not see any classic symptoms, right? There is no epigastric pain. The pain is like more diffuse pain, and it's more bilious vomiting. Maybe those are the cases you might want to get an imaging, because the symptoms might not, in that case, are not fully consistent with pancreatitis. Okay. And for chronic pancreatitis, like chronic pancreatitis means you have enough insult to cause structural changes now, right? So it can be pancreatic atrophy, it can be duct changes, it can be calcifications in the pancreas. But once you have those changes, it's irreversible. Once you have chronic pancreatitis, that's it. You have chronic pancreatitis for life. Okay. So, and also you need to demonstrate that on the imaging in order to diagnose chronic pancreatitis. So you would be able to show it on the radiology, or you would be able to demonstrate on the histology, but you might not want to do it because that's too much invasive. And you need to do it with an endoscopic ultrasound, get a pancreatic biopsy, and demonstrate chronic inflammation in the pancreas. And if you don't have those findings, if you are able to demonstrate pancreatic insufficiency with a pancreatic elastase or stool fecal fat testing, that would be enough to say it's a chronic pancreatitis now. So again, coming to the etiology, there are like so many causes you could see, but most of them in children age group is idiopathic. And you can have systemic illnesses presenting with pancreatitis as part of their presentation, like sickle cell, hemolytic uremic syndrome, sepsis can present with pancreatitis. And you can have anatomical abnormalities like choledochal cyst located at the pancreatic head can cause pancreatitis. And if you have, gallstone pancreatitis, where gallstone is blocking your sphincter of Oddi, causing pancreatitis. And you can have anatomic causes. Pancreatic divisum is the most common cause, which can cause recurrent pancreatitis. And you can also have something called annular pancreas, which can cause pancreatitis as well as obstructive symptoms on the duodenum. Because of that, it's kind of wrapped around the duodenum. It can block the passage. And you can have genetic causes of hereditary pancreatitis. You heard of CFTR, which can cause chronic pancreatitis. You heard of SPINK1 and PRSS1. Those are the hereditary causes of pancreatitis. You can have traumatic pancreatitis. You can have pancreatitis related to hypertriglyceridemia, hypercalcemia. All of them can cause pancreatitis. And the other cause is autoimmune pancreatitis, where you would look for IgG4 subclass on the blood work. So here, this is about gallstone. In this picture, you can see gallstones can form anywhere, right? It can form in intrahepatic bile ducts. It can form in common hepatic bile duct or cystic duct. But if they can pass, sometimes they can get stuck at the sphincter of Oddi. But you could see that's where your pancreatic duct as well as common bile duct opens into your duodenum. So if you're blocking that opening, what you are doing is you are causing a backflow of pancreatic secretions back into pancreas. But what happens now is you have trypsin there, which is already activated and which can cause autodigestion of your pancreas, causing pancreatitis. So that's how you'd get gallstone pancreatitis when you have a stone. And this picture shows pancreatic divisum, where in the embryonic period, your dorsal and ventral ducts of pancreas, they won't fuse. So they open independently into the duodenum. But at the same time, they are narrow, they have relative stenosis, again causing backflow of pancreatic secretions back into the pancreas, causing recurrent pancreatitis. Again, typically not seen like in very young kids. Again, Cullen's and Turner's sign. This is the ecchymotic discoloration around the umbilical area or in one of the flanks. So again, it indicates, necrotizing pancreatitis causing third spacing and hemorrhage into the peritoneum. Again, you all know about the treatment for pancreatitis. Most important thing is IV hydration. Most of these kids, they need at least 1.5 to 2 maintenance IV fluids, because one of the problems here is you have lots of third spacing. So you're not keeping the fluid in your intravascular compartment. With that, you develop a hypoperfusion kind of picture in your circulation. So there are many cases where you can have severe pancreatitis causing multi-organ failure and shock type of picture. So that's the reason why you still need to maintain intravascular circulation very well. At the same time, you need to monitor the ins and outs. You need to monitor the urinary output in these patients. And pain control is again important in these patients. Most of these medications, opioid medications, they can cause sphincter of Oddi dysfunction, worsening the course. But like these two medications, typically meperidine and morphine, are generally better than other opioids to use. So again, complications are important. Pancreatic pseudocyst is the one thing you would be looking at. Typically after 4 to 6 weeks of acute pancreatitis episode, they can still have persistently elevated lipase level. They can also have ongoing abdominal pain. So if you have that, you need to do an ultrasound to look for a pancreatic pseudocyst. And pancreatic necrosis can happen sometimes. You can also develop pancreatic pleural fistulae. And we already talked about pancreatic insufficiency. It's more common with chronic pancreatitis. And also, in order to diagnose, you need to do pancreatic elastase or fecal fat test. Okay, that's about pancreatitis. You wanna, Kelly, you wanna?
We suspect a malabsorption syndrome of the following because that is most likely to have an outcome.
What do you think? Okay. What is the reason you mentioned B12?
If you're not absorbing anything, you're not,
Okay.
that location and that thing.
Okay. What is that? Yeah, it should not be, yes. It's an 8-month-old. And again, it's a poor weight gain we are talking about here, right? So B12, it might not be, it can cause, macrocytic anemia, but it should not itself be causing your failure to thrive, right? That's one of the things they mentioned there, poor weight gain, right? So anytime if they mention malodorous stools with poor weight gain, it's fat. Fat malabsorption causes steatorrhea, right? What is the definition of steatorrhea? You don't need to have like lots of loose stools or 10 episodes of diarrhea a day. You can have 2 to 3 episodes, but they are large in quantity. You can also see bulky stools floating on the toilet water. Okay, so that's how typically steatorrhea presents, and it's very, very malodorous. So if you see that, then that's the malabsorption. In this case, so you can have vitamin B12. It can happen with celiac disease where you can have B12 deficiency, but that's not the only thing. But we are looking for we are looking for the cause of this kid's poor weight gain, malodorous stools. So it would be most likely so you do fecal fat quantification over 72 hours. So that's the best test for fat malabsorption. But in many cases, you can also do pancreatic elastase, which is an easy test. But this is like the gold standard for you to diagnose fecal fat malabsorption. So for B12, typically what you are looking for is terminal ileum, right? So you can have pernicious anemia, you can have, an autoimmune gastritis kind of picture in the stomach. But in addition to that, you would be looking at the absorption in the terminal ileum, right? So if you have a short bowel syndrome kid where the terminal ileum is resected, you can't absorb vitamin B12. So that's what you would be looking for. This kid has a short bowel syndrome where the IC valve and terminal ileum is removed. Or if you have a small intestinal bacterial overgrowth, right? And typically it involves terminal ileum. So this bacteria, it would not let B12 get absorbed. So again, that's one other cause where you would see vitamin B12 deficiency. Okay. Anybody wants to read this? Kelsey?
The girls dependent on nutrition, which means it's practical until eating, and as a result of significant affect malabsorption and small bowel bacterial overgrowth. The following the tests result that most strongly suggest small bowel bacterial overgrowth.
Any idea, guys? What is that? Yeah, that's nice. So, all right, what is that? Reducing substances. You might be able to see it, but most strongly, they use the word most strongly suggest small intestinal bacterial overgrowth, right? So most of those things can happen with short bowel syndrome, right? In short bowel syndrome, you have a rapid gut transit. So you're not absorbing most of your content, so you would have malabsorption, right? So with these patients, the problem is typically, where do you see your bacteria in your gut? In your colon, right? The colon has millions of gut bacteria. Your small bowel is relatively sterile. You have only small number of gut bacteria over there. And you have IC valve in between, which acts as a barrier to prevent this translocation, this ascending bacterial migration into the small bowel, right? So in this patient, you could see IC valve was removed, right? Now you don't have a barrier, so the bacteria can easily come into your small bowel. Suppose, just imagine you have a lactose intolerance patient And you always hear about this breath test, right? You do like a breath test for lactose, a hydrogen breath test for lactose intolerance. So what are you doing? You are giving them lactose, right? Which needs to be digested in the small bowel, but they don't have the lactase, which is supposed to digest lactose. So this lactose can go down and goes into your colon. That's where you have lots of fermentable bacteria. They are going to ferment this lactose, produces this osmotic diarrhea, and also it produces that hydrogen they produce is going to come out as flatulence, and they are going to release it in their breath. So you would have increased hydrogen, right? But again, there is a 90-minute time gap for this substrate to move into the colon, right? So typically you see that hydrogen rise after 90 to 120 minutes in lactose intolerance. But here what's happening, your gut bacteria are moving into small intestine. So now you have lots of gut bacteria in your duodenum and jejunum, right? So once you empty your stomach into the duodenum, you are going to have lots of fermentation of your regular substrates, producing lots of gas, bloating, distension. And again, this these are osmotically active substances, produces osmotic diarrhea. You would see like lots of diarrhea in SIBO cases, and you would produce hydrogen, but here you don't wait for 90 minutes. You would immediately produce the actual rise in the breath hydrogen. Okay, so this question is a little bit controversial. So because, you know, villus atrophy can also be seen in small bowel biopsies. And there, typically you should be seeing it's not the elevated fasting breath hydrogen. You would see, you give some glucose, or if you give some lactulose, those substrates will be immediately fermented by gut bacteria and produce lots of hydrogen and methane. But there are some experts who mentioned that, you know, you can have a fasting or baseline hydrogen elevation in small intestinal bacterial overgrowth. If you take that into account, that would be your answer. A is the answer in this patient. But you are right, you can have reducing substances because you're not absorbing your carbohydrates completely. So if you do reducing substances, you'd be able to find at least 1+. But again, that's the reason why the tricky part is it says most strongly suggests small bowel bacterial overgrowth. And what type of lactic acidosis you would see in SIBO? Did you guys send D-lactate level anytime from floor? So you would see D-lactic acidosis. So these gut bacteria with fermentation that can produce D-lactate, and sometimes they can present in encephalopathy. So a progressive SIBO, which is not treated, can put them at risk of encephalopathy because of this significant D-lactic acidosis. So again, anybody wants to read this? Josh? Okay, so what do you think this is? Toddler's diarrhea, yeah, very important question for your boards. So, so the most common thing is kids in between 1 to 3 year olds presents with this condition. You would be able to see 3 to 10 loose bowel movements in a day. And most of them would have increased osmotic substances in their diet, mainly juice or fructose containing fruits, or they might be taking more candies. All of those, they increase the gut transit. In addition, they have immature GI tract, which would not be able to absorb the fluids very well. So with that, they can develop diarrhea. But most important thing here is no nocturnal symptoms and no change in their growth percentiles. They continue to do very well. They might not have any abdominal pain. If they give you, they are able to see undigested peas, carrots, things like that, without any nocturnal diarrhea, without like any change in growth percentiles, answer is toddler's diarrhea. Okay, so again, it's a little bit about like diarrhea. In order to call it as acute diarrhea, diarrhea should last only less than 2 weeks. Anything lasting more than 2 weeks is chronic diarrhea. And that's the technical definition. You need to have like more than 10 ml per kg per day in younger kids, more than 200 cc in older kids and adults. But for practical standpoint, you would compare their prior bowel movements. If they have increased frequency and lose consistency, then it's going to be diarrhea in anybody. So again, there are multiple mechanisms for diarrhea. Again, these might be important for you to differentiate between osmotic diarrhea, secretory diarrhea. They might ask questions about these things. So osmotic diarrhea, again, you have a osmotically active substance inside your lumen. So osmotically active means it has higher concentration gradient, right? So with that, whenever you have higher concentration gradient inside your lumen, you are attracting more water to dilute that concentration, right? So with that, you are attracting more water. Just imagine when you give Miralax to a kid or lactulose to a kid, those two substances are not absorbable. So 99.9% of them, they just go through your GI tract, but they create a osmotic gradient inside the lumen. With that, they draw more water that makes the stool loose. So, and again, any malabsorption, suppose celiac disease, there are two types of diarrhea associated with celiac disease. One is, you don't have absorptive surface, so you won't absorb that much. With that, most of that osmotically active substances, including carbs, protein, fat, everything is in the lumen now. So which kind of causes an osmotic gradient, which causes loose stools. Okay. So the problem here is, you are drawing more water, but you are not really drawing more electrolytes, right? So with that, your lumen is diluted. That means you have lower electrolytes inside the lumen because you have like a dilutional hyponatremia inside the lumen. So with that, if you do something called osmolar gap, the formula is 290 minus 2 into sodium plus potassium. So in osmotic diarrhea, you have low sodium and potassium in the lumen, right? Because of the dilution. So that value would go down. Your 290 stays constant. So you would have a higher value, right? So if you see a osmolar gap of more than 100, it suggests osmotic diarrhea. And the most important test for that is, like if you stop, if you fast them, you're not really giving an osmotic substance, right? You're not giving them Miralax or lactulose. So you are stopping the diarrhea in osmotic diarrhea. Okay. But the examples are your like lactase deficiency, lactose intolerance is a perfect example for your osmotic diarrhea. And if you have, and again, if it is lactose intolerance, you are going to see a drop in the pH of the stool, and you are also going to see reducing substances in the stool. Okay. And secretory diarrhea, which can happen with most of the bacterial infections we see, including your regular E. coli, Vibrio cholera. What happens here is you have enterotoxins released from your bacteria, and they are going to stimulate the cyclic AMP or cyclic GMP pump constantly, so which are going to secrete electrolytes into your lumen. So your sodium and potassium are like constantly pushed into the lumen. So now have more electrolytes, right? Your 290 stays constant. So your osmolar gap is going to go down now, right? Because your 290 is constant, but sodium, potassium are high. So this value is going to be low, the resultant value. So it's going to be less than 100. Okay, so then again, so the most important thing with this is it persists during the fasting, right? If you have a diarrheal illness going on related to acute gastroenteritis, doesn't matter if you feed them or not, they are going to have constant diarrhea. But that's the acute causes of secretory diarrhea. You can also have chronic causes like tumors, like a carcinoid, VIP tumor. What they produce is they again these VIP is constantly going to stimulate the cyclic AMP GMP pump, causing the diarrhea you see in these patients. Again, inflammatory process. Again, acute causes include your invasive diarrheal infections from like Shigella, Salmonella, Campylobacter, Yersinia. All of them can cause inflammatory diarrhea. What they do is they invade the mucosal cells, and they also there is a lack of mucosal integrity because of the damage. So with that, your WBCs, RBCs can escape into your stool, causing the bloody stools you are seeing, and also increase the WBC counts. And when they mention about cytotoxic process, one thing I want you to remember is, rotavirus or other viral diarrheas. What they do is they transiently damage your villi inside the small bowel. So when that happens, you have like a flattened villi, so they won't absorb the content. So you have a decreased absorptive surface. Because of that, you develop an osmotic diarrhea in these patients. Okay, here, causes of all the infectious agents, secretory. So you are actually invasive diarrhea organisms. They can also cause secretory diarrhea. So they can have both mechanisms. They can cause secretory diarrhea from the enterotoxin. They can have invasive diarrhea from their inflammatory process. So if they ask you about Shigella, Salmonella, Yersinia, they can have both inflammatory plus secretory component. Again, I think we kind of discussed this during previous slides. Decreased surface area. We discussed about short bowel syndrome. You don't have much absorptive surface. Celiac disease is the same thing. Again, rotavirus, as I mentioned, you're damaging the villi, so you're decreasing the absorption capability. Increased motility. So whenever you see increased motility, things, the conditions you need to think of are irritable bowel syndrome, where you have rapid transit producing frequent diarrhea. If you have thyrotoxicosis, that can also produce rapid transit and diarrhea. So this is the pancreatic insufficiency kit. It can produce greasy, foul-smelling stool. Diagnosis by fecal fat. 72-hour fecal fat testing is preferred. But if that's not available, you can do a qualitative, that means single spot test on the stool to look for any fat globules. You can also check for, stool elastase. But many of these patients, they definitely need rule out cystic fibrosis as the cause of their pancreatic insufficiency. So again, post-infectious enteropathy, this is one of the common things we see daily in the clinical practice, right? Kid has a viral gastroenteritis recently. For next 4 to 6 weeks, they can have ongoing diarrhea. Parents are very worried. But now I think you got the answer, because what a rotavirus gastroenteritis is doing, it's destroying your villi, and where are these brush border enzymes are sitting? Brush border, as the name suggests, you have your lactase, sucrase sitting on the tip of the villi. So for any reason, if you are damaging your villi, it might be celiac disease, or it might be a viral gastroenteritis. So what happens for the next 4 to 6 weeks, it might take time to regrow your villi, right? But this is not like celiac disease. You don't have a constant insult on the villi to keep you chronically inflamed or flattened. But here, once the rotavirus is gone, your villi can grow back and you can regenerate your brush border enzymes. But until then, if you give them lactose or dairy products, they are going to have lots of diarrhea because you are not digesting your lactose. But sometimes because of this decreased absorptive surface, you can also develop diarrhea related to other substances as well. But most of the times, avoiding lactose or giving them lactose-free formula would be good for a period of 4 weeks. Okay, so any of the viral gastroenteritis, you might need to refeed them early. You don't wait because luminal contents can act as growth factors for these villi to grow back faster. And in addition, there is no role for diluted formula. So if it is full strength or diluted, it's not going to make much difference based on the studies, although that's what we use most of the times. And BRAD diet is not recommended. No need for BRAD diet. It's not going to make any changes. And other treatment options like antibiotics, they are typically not indicated in any of these gastroenteritis, except Vibrio cholera or Shigella and Giardia are the causes where you might want to use antibiotics. The rest of them, you would use them in selected circumstances. Suppose if you have Salmonella in a very young infant and they have more than 10 stools, high-grade fevers, you might want to use antibiotics. So it's based on circumstances, but one case where you should not be using antibiotics is your O157H7. Never use antibiotics. So whenever they give you antibiotic option, that means it's tricky in exam. They want you to rule out O157H7. If you give it, what are you doing? You're destroying the bacteria. You're releasing the toxin into the circulation, which can cause HUS, hemolytic uremic syndrome, right? So you want to avoid antibiotics there. And again, zinc, in certain kids who are significantly malnourished, they can have zinc deficiency, which can cause diarrhea. In those kids, giving zinc can fix the problem. So I don't know if we have. So it's until 1:15 or okay. So I might try to skip this, because this is like most of them, So here, one thing is why you should not be giving cow's milk to an infant, right? You could see the osmolarity difference or concentration difference there, right? Breast milk, the cow milk has approximately 3 times concentration to your breast milk. And it's 2 times the concentration of your infant formula. If you're putting that much load on your kidneys, right, it can cause osmotic diuresis. So these kids would be peeing a lot and falsely reassuring parents that he's peeing, right? But they would develop dehydration. And in addition, it can cause like renal overload as well. So never use cow's milk in infant. Again, do you need to give iron supplements in a kid less than 6 months on breastfeeds? No, right? Because, unless mom is significantly iron deficient during pregnancy, that's a different scenario. But if it's a normal pregnancy, kid is breastfeeding, the supplies would be enough because the bioavailability of breast milk iron is very good. But vitamin D, you need to supplement because it's not enough. And again, if you have a vegan mother who's breastfeeding, you need to monitor the B12. What is that? Okay. Again, I'm not really sure if you have enough time, but I would go into questions. If there are any interesting questions, 1 second. So this question, this is like, bright red blood after a recent viral gastroenteritis, right? So when you have clear vomiting followed by turning into bloody vomiting, Mallory-Weiss here is the answer. Here, the mother of a 4-year-old boy has noted blood in the toilet tissue and small amount of red blood in the toilet water. She states the boy bowel movements have been regular and he has not experienced pain with their passage. His appetite, activity, sleeping pattern has been normal and he has had no abdominal pain. Of the following, the most likely cause of a child's bleeding is. So what do you think? So when you have painless bleeding, the 2 things you might be thinking of are either a juvenile polyp or Meckel's diverticulum. Meckel's diverticulum causes a large amount of bleed. And most of the times it's mixed with stool. But here, the fact that it was seen more on the toilet paper indicated the more distal location, right? So that's what juvenile polyps do. They would be mostly located in the rectosigmoid colon. So your bleeding would be like mostly on surface of the stool or more into the toilet bowl on the toilet paper. But the other thing you'd be thinking of is like an anal fissure, right? But it's very painful. So here they mentioned like it's not painful. So that's how you're kind of ruling out anal fissure. Yes. No, you would not, because if you're suspecting juvenile polyp, it has to come out, right? Yeah, it can come and go. It can come and go. It's based on the pressure put on by the actual stool. Sometimes they bleed, they might stop bleeding, they might re-bleed later. So if it is like constantly happening recurrently, then you definitely need to do a scope and remove the juvenile polyps. Not only for that, you want to rule out any polyposis syndrome, right? You can have a juvenile polyposis syndrome if you have more than 5 polyps, that increases your cancer risk. But if you have like a simple juvenile polyp, 1 polyp, the risk is only like less than 10% for malignancy. So although they are at risk for recurrence, they don't need this constant surveillance. If they have recurrent bleeding, you would rescope them and remove the polyp. So again, this is a tricky question. Did you guys do it before? So this it seems like they described, milk protein allergy here, right? So the big kid's birth weight is 3.5 kg, and he was able to grow up to almost 7 kg at 3 months. That means he's growing very well, right? So they are explaining a benign condition here, right? And here, he has been passing this bloody stools and mucoid stools, the mucousy bloody stool, and there is a small anal fissure. So again, the small anal fissure is more like a distractor, but this is not the cause, because it should never be causing mucus stools, right? So if cost were the issue, what would you most likely to recommend? Would you go for casein hydrolysate, which is the actual true treatment for your milk protein allergy, versus soy protein formula? Yes, that's the reason. So that's the tricky situation. But unfortunately, 25 to 50% of milk protein allergy babies, they can have a coexisting soy protein allergy because of the cross reactivity. So that, what does it mean? Remaining 50 to 60%, they might be able to do well, but sometimes you might need to take both soy and milk from their diet.
How long do you
So typically the guidelines say 2 to 4 weeks, but most of the time you would be able to see a difference in 3 to 7 days itself. But as per tests and guideline recommendations, it should be like 2 to 4 week trial you need to give for any formula before saying it's not working. Again, so it seems like they described an intussusception case here, right? So he's been having these intermittent episodic pain, and in between child falls deeply asleep and difficult to arouse, and has bloody diarrhea and abdominal pain. So what is the most appropriate test for management of this child? Right, that's true. Yeah, so it's like in some cases you can do abdominal ultrasound, but that's not the answer, because here it's both diagnostic and therapeutic. So again, this is a esophageal varices case, and they wanted you to see what is the most common, if it is like not coming from gastritis or peptic ulcer disease, but coming from esophageal varices, what is the finding you would choose? What do you need to have in order to cause esophageal varices? You need to have something called portal hypertension, right? What does it mean? You might have a portal thrombus, or you might have cirrhosis, which is obstructing the blood flow through the liver. So it's kind of pushes back. So it goes back into spleen, enlarges the spleen, traps platelets. So you would see hypersplenism, right? So you would see splenomegaly with at least decrease in 2 cell lines. It might be your hemoglobin, or mainly platelets would be down, but you would see like WBC decrease or RBC decrease. And again, this is an interesting question. 3-year-old girl, history of blood in her stool. She has 3 large mushy bowel movements that parents say had about 2 tablespoons of blood mixed in each stool. So here they are saying 2 tablespoons with each stool, right? So each tablespoon is like 15 ml, right? 15 ml, 2 tablespoons, 30 ml with each bowel movement. So in the last 12 hours, this kid has almost 100 cc lost. So I would think this as like a Briscard, like a larger bleed when compared to the previous juvenile polyp, right? But the other thing they mentioned here is they mentioned about dark red stool. So again, that's a tricky word, right? If you have melena, how do you describe it? Black tarry stool. If you have bright red blood or hematochezia, you would say bright red. If you have dark red, what does it mean? It's in between. That's more maroon colored stool, right? So you need to think of like maroon colored stool. And this kid, if they ask you for the most appropriate diagnostic procedure, again, they are not asking the next step. They're asking most appropriate diagnostic procedure. So it would be, Meckel's scan to diagnose Meckel's diverticulum. So, I have lots of slides on, GI bleed, but, we don't have enough time, seems like. So you can see, I might be able to send these slides to you guys. So because, you know, the bleed, so clinically also it would be helpful, you know, to differentiate how is hematemesis, how is coffee ground emesis, how is melena, how is your hematochezia looks like, how is your maroon colored stools looks like. And guaiac, what are the foods which can cause false positive guaiac, false negative guaiac. Okay, so this is like one important question they might ask you. You need to know what can cause false positive reaction, right? So anything which can have a peroxidase activity or oxidizing activity can produce, you know, positive guaiac. So, and false negative is only one thing, which is vitamin C, which is an antioxidant. So it kind of causes a false negative. What is that? Right. So typically not that much, but for exam purposes, that's important. Okay, what I would do is, you know, I can send these slides to you guys, but this is like one important slide I want you to go through as like, you know, questions, what type of questions you would ask. And this is like a very important slide for your exam. So whenever they give you a lower GI bleed, you might want to, the first thing you might want to look at is whether it's painless versus, you know, painful bleeding, right? So if it is a painless bleeding, you would, as I mentioned, you would look at juvenile polyps and the Meckel's diverticulum. If it is painful, again, you would look at this anal pain versus abdominal pain. If it is anal pain, then it's going to be your anal fissure. But if it is abdominal pain, again, you have few other causes, right? The most important one is, you know, your intussusception and henoch-Schönlein purpura. Both of them can cause, you know, abdominal pain with blood in the stool. Okay, so I think I would stop it here. I think we are.
Thank you.
No problem.